I call the meeting of the Health Insurance Reform Commission to order. We have 5/6 of a quorum that's here right now, and we are going to have another member of the House of Delegates that will be participating on by phone. So we'll start out and we introduce the members. I'm George Barker, State Senator, and I'm chair of the Health Insurance Reform Commission. Senator Surville.
Scott Surville, I represent the 36th Senate District, which for the next 3 months is Fairfax, Prince William, and Stafford.
Senator Spruill, statewide.
Senator Spruill is the senator of the universe, the cosmos, I think. Steve Heretic from the 79th Vice Chair.
Wendy Goditis, representing House District 10 in the House of Delegates.
All right, staff, want to introduce yourself? Tom, introduce yourself.
Tom Stevens, Legislative Services.
Marvi Ali, Legislative Services.
All right, thank you all for being here today. We're going to do a couple of things today, and then there'll be probably 2 more meetings at least for during the rest of the year. We had one meeting back in early summer, I guess it was. What we're going to do at today's meeting is start out with a couple of presentations dealing with a significant policy issue that was where there were bills that were proposed by Senator Chap Peterson to address this policy issue. He could not be here today, but he may be able to be here at the next meeting. It's a policy issue dealing with vertical integration of healthcare entities. In this particular situation that has sort of spurred this bill, there have been entities that have hospital and health insurance characteristics to their portfolio. And it's an issue that is not an insignificant issue. It's an issue that is being addressed and has been addressed in a number of other states around the country, so that there are guardrails put in place to try to make sure that there's not, in effect, preferential treatment or punitive treatment, depending upon which size of the case that you're looking at there. What we're going to do is to have some presentations from the 2 entities that have sort of spurred our focus on this and led to the bills that Senator Peterson put in. That will start out with the presentation from Chesapeake Hospital, and then have the Centera and Optima entities present something. What I would hope we would do today is get a lot of information and get people more familiar with the issue and help and understanding the potential issues with it. And then hopefully at the end of the presentations, I guess we don't necessarily have a quorum here right now, so if we don't have a quorum, we can just proceed to basically set up a stakeholder group to try to work on this issue and see if we could find a middle ground that takes into account everybody's interest and in particular the interest of the purchasers of health insurance and the patients at the facilities themselves. And so with that, I'll call on individuals from representing Chesapeake Hospital to make the presentation.
Thank you, Mr. Chair. I appreciate the opportunity to speak to you today and
Certainly.
Members of the Commission. My name is Paul Harkaway. I'm a pulmonary and critical care physician by trade, coming from the great state of Michigan in Ann Arbor. I practiced for 20-some years in critical care and pulmonary medicine, but also got very involved in management work back in the 90s with a focus on community health and well-being and developing systems that could do a better job accomplishing and meeting healthcare needs from a community perspective. As we all know, Our healthcare system has some great points of excellence, but it also has a lot of areas that we still think need focus, and cost being certainly one of them. I worked as a president of an independent physician association for some 20 to 30 years that brought physicians together to do this kind of work. And then I worked as a senior vice president for clinical integration and accountable care for the Trinity Health System, which is the third largest nonprofit health system in the country. So I spent a lot of my time and energy, again, trying to get different folks together to improve the care that we provided and manage the cost as well. I've been retained by Troutman Pepper on behalf of Chesapeake Regional, along with Bruce Solomon, to study and co-author a white paper related to vertical integration and its impact on the community and the providers that also provide care within that community. We, in fact, developed the white paper, which we'll be distributing to you today, and hope that you'll have the opportunity to review it. I knew that would happen. Thank you. Our purpose is to advise on proposed legislation that you're facing in the Commonwealth that would potentially regulate vertically integrated entities who own both a hospital and a health insurance company. As we looked at this work, and it has been the foundation of my work and Mr. Solomon's as well, we used the triple aim as our true north to try to assess concerns and address potential remedy. The triple aim was coined by Don Berwick many years ago to try to focus on where we needed to pay our attention in order to try to improve the delivery of healthcare. And it basically focused on improving quality, enhanced access, but also decreased cost, because traditionally as providers and physicians included, we haven't focused on cost as much as perhaps the other measures. So that's how we framed up our review of the opportunities and what might be looked at from your perspective so that we could advise you effectively on what alternatives you might have to consider to address some of the concerns. Our methodology, we analyzed 47 peer-reviewed publications and state and federal testimony. We reviewed publicly available data from the Virginia Health Information from CMS, Center for Medicare Services, and Leapfrog on both quality and cost. And we reviewed relevant legal filings from multiple states related to this issue. My last comment before I turn it over to Mr. Solomon, about the time we started this work, a book was published, and we had in fact focus of this book is to discuss the pros and cons of vertically integrated systems and some of the concerns that might be addressed. And it also talks about potential remedy. So I would encourage anybody who really wants to do a deep dive into this, that this would be an excellent resource to you to understand the literature that's out there, what's been accomplished, what hasn't, and potential remedy. With that, I'd like to turn it over to Mr. Solomon.
Thank you, Dr. Harkaway, and thank you, Mr. Chair, member of the committee, for allowing us to speak today on this really important topic. My background is 30 years as a healthcare administrator. I've overseen the operations of vertically integrated delivery systems, academic medical centers. I've done a lot of work in accountable care development, and also have a lifelong commitment to vulnerable populations, having actually left the Brigham and Women's Hospital to go run the Boston Healthcare for the Homeless program for a number of years, and still on the board of several organizations dealing with vulnerable populations. For the purpose of our work, I want to define what is vertical integration. It is one entity that provides the goods or services at multiple levels in the chain of distribution. Thank you. So a modern example is Netflix, that produces content and also provides streaming services. But this is not a modern business structure. It's been around for hundreds of years. So Carnegie Steel and Henry Ford didn't just mine the ore and produce the cars. They distributed the cars. They sold the ore. So it's a structure that is fairly common around the world. As it relates to healthcare, vertical integration often involves the combining of hospital, physician, and health insurance services into one entity. And the proposed legislation addresses vertical integration specifically between a hospital and a health insurance carrier. And that's what our focus is. So first, why is vertical integration a concern, and why should this body be interested in it? Vertically integrated entities can and do use control over their insurance networks to exclude or disadvantage provider rivals. Specifically, there's been the Any Willing Provider laws that's been on the books for a long time have gaps in it. And the gaps are because they were created before the modern structures of insurance products have been around. And it permits exclusion of lower cost ambulatory facilities. So let me give you an example of how that may affect consumers. As you probably know, high deductible insurance plans have become much more common. And the trend is an increase in those high deductible plans. So an individual who has a high deductible plan of approximately $5,000, and that's not uncommon, would have to pay the first $5,000 out of pocket. So if they needed a minor surgical procedure, they would have to pay out of pocket. And clearly, they would want to do it at a quality organization that has the lowest cost. So if the lowest cost ambulatory facility is not in the network that they have their high deductible plan, they're going to be financially disadvantaged. Second, Any Willing Provider laws do not address the modern tiering and steering of networks, and including vulnerable populations. And like I said, it was because the law was created before a lot of these structures were around. But to give an example of how that may affect folks, I mentioned that I went to run the Healthcare for the Homeless program in Boston. Well, I left because in Massachusetts at the time, there's a movement to move homeless, vulnerable populations into managed care plans. And those managed care plans had many of their access points in locations that homeless people would have a hard time getting to. So if the tiering and steering is to locations or access points that make it difficult, it will be, those folks will be the least vulnerable, the most vulnerable will be affected by it. And lastly, there's an impact on care, access, and consumer costs, as I mentioned, especially those with high deductible plans. This is not just theoretical. There's been lawsuits in Pennsylvania and Florida against vertically integrated entities that show these risks are real, and they are in specific situations not too dissimilar to what we're talking about with hospitals and that own insurance carriers that are accused of abusing their power. In the white paper that Dr. Harkaway referred to and that will be distributed, we provide some detail about that. As Dr. Harkaway mentioned, we did a thorough evaluation of the research, and our approach was to look at it from a broad perspective on the issues related to healthcare delivery occurring nationwide. And we found that the research consistently shows that vertically integration leads to higher costs without an improvement in quality. Now, it's important to say that all the research that we found, which is significant, there are 47 references in the white paper, are about vertical integration between hospitals and physicians that show this. There is nothing that we found that's peer review published around hospitals and insurance companies. We believe, though, that the negative effects, the potential negative effects of vertical integration would actually be worse with the vertical integration with insurance carriers and hospitals. We did a deep dive because we wanted to take an example. And here in Virginia, the Hampton Roads situation is a really good and extreme, in our opinion, example of a vertically integrated provider, Centera Optima, who performs the same or worse on quality and access points, and its costs are higher than its non-integrated competing hospitals and insurers. So a couple of pieces of information related to that. Their Medicaid Advantage plan has a star rating, which is one of the publicly available pieces of data that is the lowest in the country. They have one hospital with a 5-star CMS star rating. And I would think, as a hospital administrator, a system that has significant resources would invest those resources to move up in the star ratings. And lastly, Centera is an example of a market where they have over 70% market share, and that is significant. I live in Boston now, and in Boston, the largest, the sort of 800-pound gorilla was called Partners Healthcare, is now Mass General Brigham. Their market share is around 30%. And they're the dominant force in Boston. So 70% is, I believe, at least to my knowledge, the highest of any, within any significant city in the country, which leads to also issues around consolidation, around competition, which takes away access to consumers again. So our recommendations. Really, what can you do to prevent the negative effects of vertical integration in Virginia? There's a risk of abuse just by the nature of the power involved in these vertically integrated structures. Other states' real experience with this, the rapidly evolving market that it would suggest try to stay ahead of, and the lack of a clear community benefit relating to quality and cost and access leads to our conclusion that vertically integrated entities should be regulated to protect consumers. So we believe that there should be ensure equal opportunity to participate in the vertically integrated structures, insurance structures networks, and not just anyone, but that should be subject to objective requirements of quality, cost, and access. So you have to sort of, that needs to be applied to the vertically integrated providers, physicians and providers, as well as those from the community. And this relates to clearly cost and access for consumers, so that the physicians aren't excluded from insurance plans that may stop them having access or having to pay for higher costs elsewhere. Second, we're suggesting prohibition on directors of vertically integrated insurance plans from simultaneously serving as an officer and director of an affiliated healthcare provider. So in the Centera example, someone we're suggesting not be on the Centera Health Delivery Arm Board and the Optima Board. And then relatedly, that there should be separate boards for hospital and insurance carrier entities with the additional suggestion that there be community representation. And these last two are really to ensure that decisions are made in the best interest of consumers and that there avoids conflicts of interest or potential conflicts of interest. We engaged in this because of our commitment toward, our lifelong commitment toward wanting to facilitate the triple aim being the direction of healthcare organizations that we've worked at, and the belief that legislatures like in Virginia can really aid in the direction that benefit consumers. We hope that our work, after you read our white paper, will aid the Commission to ensure appropriate response to protect consumers and put appropriate guardrails in place. So thank you very much, and we're open to questions.
All right, does anyone have any questions of the speakers here?
I do, Mr. Chair.
Yes. Senator Goditis.
Thank you, Mr. Chairman. So hospitals have borne the brunt of COVID, and they have lost so much. And they're still bearing that brunt and possibly getting worse and worse. We did a couple of things. We created Virginia's new, its own insurance market and this new path of reinsurance with the hope that costs across the board would come down. I don't know that we know enough about the effect of that yet. So isn't it possible that as costs lower as a result of those things that a system like Centera might feel the need to compete and will not be charging more for insurance? I mean, is there a market question here where they kind of have to stay with the market?
Well, I'll take a first shot and see if my colleague responds. So first, I'm not familiar with
Could you
any market.
stand near
I'm
the
sorry,
microphone?
Mr.
Yes,
Chair,
please, thank you.
and I'm sorry about the protocol. Bruce Solomon. Is it okay to respond?
Yeah.
Thank you.
Yeah, just speak with the mic.
I'm not familiar with any significant marketplace where costs have gone down in the community via these efforts. First of all, I agree with you substantially about the amazing work that hospitals and health providers have done during COVID and how they've, including Dr. Harkaway, been on the front end of this. That being said, I think the structure of the system, the incentives and the priorities make it so it's very difficult, whether it be Centera or any other large system right now, to sort of decrease their costs. Now, the reality is there's a balance of, if you have an insurance company and a provider, you know, from a business standpoint, they are evaluating what works in the marketplace. So they do have to compete in a marketplace. But if you look at the overall total cost and expenditure of healthcare, it's not going down anywhere that I know of.
Mr. Chair, Paul Harkaway, I would agree. I'd like to see evidence of where premiums are going down in healthcare, including my own personal experience and people in my own community. So all we see is costs going up and premiums going up, and more intensive cost shifting directly to the consumer with higher deductibles and higher copays. Unsustainable. Everybody said that for a long time, right? And in fact, when you get into these high deductible, high copay arrangements, people start to neglect needed care, which ultimately not only harms them from a health standpoint, but it causes more costs further down the road. So I would say the train's off the track currently, and without any evidence that it's going to get back on, to really take responsibility for driving the premium either flat or down. Thank you.
Thank you, Mr. Chairman.
All right, are there other questions?
Mr. Chairman, I got a couple of
Yes,
questions.
Senator Searle.
Thanks, and appreciate your presentation. We deal with these issues in a lot of different spheres. You know, the vertical integration versus the forced competition model. You know, we deal with it in beer, we deal with it in cars. You know, we have the three-tiered system, whatever. You know, we let craft brewers be vertically integrated brewers that sell to the public, whereas everybody else has to go through a distributor. Same thing with cars. Now marijuana, I guess, medical marijuana, we have vertical integration, but with retail, we're probably going to have three-tier. And so, and I understand healthcare isn't beer, cars, alcohol, or marijuana, but it's a little different pressures on it and whatnot. But one of the biggest factors in the medical side that I didn't hear mentioned in your presentation is COPN. And I was just, the certificates of public need and the restraints on competition that we impose on the system through that. And I was just curious why there wasn't a mention of that within your presentation and sort of how that played into whatever your analysis was, because I didn't hear it talked about.
Mr. Chair, Bruce Solomon. I'm only familiar in two states, New York and Massachusetts, of CON structures being very political and not achieving the goals of what they want. And in our research, do not believe that that is an effective mechanism completely. It is a tool, clearly, and I think it's a reasonable tool, but we thought these other suggestions were more appropriate for the issue of vertical integration guardrails.
Okay, Mr. Chairman, further, I'm sorry, go ahead.
Yes.
Yeah, Paul Harkaway. I think same conclusion. They don't seem to have had the intent, right? They've had intention that lasts for a while, but ultimately, again, if you look at total cost of care, it just keeps going up. And secondly, I would just like to comment too that the big difference with the craft brewers and marijuana and everything else is there's a lot of competition, and a consumer has a lot of choice in where to go, and that's not necessarily the case with healthcare, and frequently isn't. Thank you.
Thank you, Mr. Chairman. Yeah, thanks. And well, and I appreciate there's a lot of criticism of COPN, but I mean the reality is that we have it, and we have to sort of deal with it, and it's just healthcare is one of the most complicated markets. It's regulated from so many different ends that it's hard to make heads or tails of it half the time. But that COPN piece is something we have to deal with because it's part of what we have in Virginia. The second question I had was, you didn't mention anything about any of the other vertically integrated carriers around the rest of the Commonwealth, and I know we have other carriers in other parts of the Commonwealth, and I mean, I was just curious, in your research or your studies, whether you found there was anything that was particularly unique about the Hampton Roads area or specific to it that make it a special case or something compared with anywhere else, and whether there's any research to sort of validate that. There's some threshold or some bright area, gray area, another bright area in looking at these things, or what?
Mr. Chair?
Yes.
Bruce Solomon. We mentioned and used Hampton Roads because it is an extreme example in the state. And remember, this presentation and our work is specifically about vertical integration between hospitals and insurance plans. So there's really only a couple of markets where presently that's the case. And Hampton Roads is the largest of those markets, the most developed and most extreme example. So that's why we focused our deep dive there, if you may.
Thanks.
All right. Are there any other questions anyone has?
Yeah, no.
All right. Well, thank you very much. And we'll be in
Thank
touch.
you.
So, yeah.
Thank you.
All right. Centera/Optima. So.
Thank you, Chairman and members of the Commission. Today I stand in opposition of the Senate bill before you. I'm Colin Drostowski, and I serve as the Senior Vice President of Provider Network Management at Centera Health Plans. I have been in managed care industry for 30 years in both local and national roles, always working directly with providers and always working on behalf of the members we are privileged to serve. Let me start by just clarifying and emphasizing a point that my colleagues made earlier, and that is the analysis that they looked at does not align with the definition of vertically integrated network that they put forth. Specifically, the bill looks at hospitals that also own a health plan, but the data and information that they provided per their own admission did not look at that. So it's important to understand that they're making assumptions about what may or may not happen, not facts. I do want to share some important facts with you. First, they mentioned quality and that there was no evidence that Centera, as a vertically integrated delivery network, provided different quality. In Hampton Roads was where they specifically referenced that. The most recent U.S. News and World Report was just released in July of 2021. The top 3 hospitals in Hampton Roads were all Centera facilities. Those are facts. Centera Health Plans is part of Centera Healthcare and offers insurance products throughout its subsidiaries, Optima Health and Virginia Premier. Since 1984, Centera has operated as an integrated delivery network, an IDN. This is a health plan which is owned and highly aligned between both provider and payer in order to create more affordable, higher quality health insurance products for consumers. Our plans cover more than 900,000 members in Medicaid, Medicare, the Health Benefits Exchange, and commercial products. We have been chosen as a state employee health plan in Hampton Roads and several other localities across Virginia. We take special pride in serving the most vulnerable Virginians, and as a result, our Medicaid plans have the highest consumer satisfaction and prevention ratings in Virginia, according to the National Committee for Quality Assurance. We are immensely proud of the work with the Commonwealth to expand Virginia's Medicaid coverage. This achievement has provided vital health care access to hundreds of thousands of Virginians. With all of that being said, these bills are contrary to the objectives of ensuring affordable, accessible care and would materially diminish our ability to do so. It's difficult to speak precisely about the impact that this legislation will have on cost and quality, but we can say that it will create significant obstacles to improving quality and will dramatically increase costs to consumers and employers. We strongly oppose this bill as it will, 1, substantially raise healthcare costs for the individual residents of Virginia, as well as for employers and for the Commonwealth itself. 2, it creates an uneven playing field for national health insurers over local businesses by adversely affecting the only 2 Virginia-based not-for-profit health plans that cover 42% of all Medicaid lives in Virginia. 3, it sets a precedent by mandating reimbursement rates for providers regardless of their scope of services, their efficiency, their geographic coverage, and it usurps already negotiated private contractual arrangements between payers and providers. And fourthly, it potentially harms our members by not allowing quality standards to be imposed on providers in our networks. This legislation will threaten the very viability of the integrated care in Virginia, despite a growing understanding that true IDNs, health plan, and provider are a vital and transformational solution to our healthcare access, quality, and affordability crisis nationally and here in Virginia. The legislation requires that any provider which desires to be contracted as in-network with Centera Health Plans or any other IDN be allowed to do so without regard to consumer preference, a provider's outcomes, technology and data capabilities, and any other factors that are used to evaluate a provider and their network participation. Furthermore, it precludes us from developing meaningful provider-specific incentive programs to help deliver better, more cost-effective care to the consumer. These requirements apply only to hospital-affiliated IDNs and not other HMOs in Virginia or health plans, despite the fact that Centera Health Plans already has one of the broadest networks in Virginia. Furthermore, Centera Health Plans and any other IDN may be forced to offer networks that the consumers may not desire at prices they simply cannot afford. Consumer, employer, and state costs will increase with no demonstrable increase in value. This is truly the antithesis of industry trends and the current best practices that health plans use to promote appropriate care and better outcomes. Centera operates two of the lowest cost, highest quality health insurance plans in Virginia. We have made significant investments in our providers to ensure that they are trained to the height of their field, have access to the best technology, and are expert in the systems and processes necessary to ensure the highest quality. These investments help to eliminate waste and unnecessary care, two major cost drivers. Not all providers have made these investments, but these bills would require us to treat them as if they had. We focus on creating efficiencies that benefit the health and wellness of our communities and members we serve, not our bottom line. While large out-of-state health insurers make decisions based on how it impacts them financially, Centera Healthcare and Centera Health Plans make decisions based on what's in the best interests for the health of our patients, our members, and the communities we serve. It's simply the right thing to do. Our integrated delivery system aligns provider and health plan goals with our members and patients in order to yield lower provider costs, lower premiums, and improved quality of care. Our model is similar to the integrated model Kaiser uses. Both organizations operate health insurers, hospitals, and provider clinics and leverage their resources for the benefit of individual members. However, Centera uses a much broader and open network of providers to deliver care. We partner with contracted providers to meet goals rather than employing all of them. It's important to note we contract with every hospital in the state of Virginia. That is a fact. We contract with 97% of primary care physicians and specialists in Virginia. It's interesting to note that Centera's broad network model is singled out by this legislation, while Kaiser's more restrictive and narrow model is exempted and can continue to operate as any other HMO simply because Kaiser doesn't yet own a hospital in Virginia. Back to the facts. The benefits of our approach are made clear by the data. Specifically, Centera is among the top 15 health systems in the nation as recognized by IBM Watson for the second time. Compared to the national average, a Centera patient is 13% less likely to die and 22% less likely to have a complication or an infection. They are more likely to have a shorter stay and experience a faster turnaround time in the emergency department. Our customer satisfaction scores are 6% higher than average, and we do it all at a lower cost with a 5% lower Medicare spend per Medicare beneficiary. In addition, our health plan products drive competition across the Commonwealth. Again, for example, in Hampton Roads, health insurance premiums are on average 10% lower as compared to the rest of the Commonwealth. And that is due to the existence of our health plan and due to the existence of Centera as an integrated delivery network. It creates healthy and needed competition among insurers, and the premiums, the price the consumer pays, reflect that. Virginians should find it deeply troubling that these bills would seek to mandate contracting with a provider without consideration for the provider's level of clinical outcomes. As healthcare providers, we should be focused on ensuring high quality, affordable, high value, and accessible care for Virginians. We feel these bills will take away from us and other integrated delivery networks and will only harm the residents and consumers of Virginia. Thank you for allowing me to testify, and I'm happy to answer any questions.
Thank you for your presentation there. Anybody have questions?
Mr. Chairman, I have a question.
Senator Searle.
Thank you, Mr. Chairman. So I had a question about the quality measures that you've talked about. And first of all, you mentioned I guess, the outcomes and the quality measures. My first question is like, where is there some public website or somewhere where you can see all that? Like, if I wanted to go and see how the hospitals in my district stacked up against each other or against ones in the state or nationwide, is that, it's like a Consumer Reports thing I can go to find that? Or
Some information, sir, is available and some is not. It depends on the source. For instance, U.S. News and World Report does publish some of it. Others of that information you actually have to purchase to have access to. There is Medicare data that is published, so it really depends on the source. But certainly Centera is happy to share our results publicly.
Mr. Chairman, additional question.
Senator Serville.
So when I'm looking at that kind of data, and you say ours is, we look at quality and quality of providers and all this stuff, how can you tease out whether the reason that people are 13% more likely to die or not die or whatever it was are a function of the care provided versus the patient population walking in the door? I mean, if you go up to where I live, you go up to the old DC General Hospital, I'm sure they had one set of outcomes, and I'm sure you go across the Potomac where the people are a lot wealthier, and you go to one of the Inova hospitals in Fairfax County where people aren't getting, the injuries are different, the health care that the people coming in is different, the physical condition is different, you get different outcomes. I mean, how do those comparisons tease out that issue?
Yeah, thank you for asking the question, and you're actually making a very relevant point. And so what you're speaking to is the severity or the complications that differ from one market or one population to another. Much, if not all, of the quality data are severity adjusted or risk adjusted to reflect the complexity of patients that one hospital receives versus another. So it's age adjusted, it's sex adjusted, it's adjusted for comorbidities. It looks at expected versus observed ratios to calculate those outcomes. That information is then enhanced by the fact that we as an integrated delivery network can seamlessly work both with our employed physicians and our employed community as well as our contracted partners on behalf of the member, on behalf of the patient, and do so through a benefit design and a health plan that maximizes those opportunities for that member.
Okay, so
Yes, Senator Serville.
So you're saying most of these people that do these quality, or most or all of these people who do these quality ratings get into that level of analysis? Or, I mean, even like the U.S. News one is
They
that
are
complicated?
adjusted. They are adjusted for severity and complexity. Yes, they are, sir.
All right, okay.
All right. Any other questions? Delegate Goditis.
Thank you, Mr. Chairman. So my guess is that most hospitals, certainly good ones, understand local needs and are a major employer in wherever they are. So they are providing these services to their employees and to their employees' family, neighbors, friends. What I'm getting at, is there any, we've heard this good data, is there third-party data showing huge dissatisfaction with the system as it stands? Do we have data that, I mean, again, I tend to think that hospitals have to be supported because they must provide care to everybody. And we've heard the good statistics. Are there bad statistics? Is there data saying people are unhappy with the system?
I'm not sure if I can answer the question the way you're intending it, Delegate, so please correct me if I'm wrong. But Centera does survey both our members that are part of our health plan, as well as those who receive care from Centera, the provider. We look at things called a Net Promoter Score. We look at satisfaction. We look at their likelihood to refer a family member or a loved one to us. I don't have those statistics as we stand here today, but I can tell you that we perform very well, and that on the health plan side, our Net Promoter Score is by a significant margin higher than those of our national competitors.
Thank you, Mr. Chairman.
All right, thank you. Any other questions? All right, well, thank you very much. I appreciate both parties making presentations today. Since we do not have an official quorum, not having 3 House members in person today. We will not take any votes on anything, but what I would tell you is that my intent is to convene a stakeholder group to deal with some of these issues and try to come up with some recommendations on that. And that those who are interested in participating in that, please let staff know and myself so that we can move forward on that and try to get to resolution on this issue so it's not, we don't have to have a third bill put in by Senator Peterson this coming year to deal with that. And we will convene a group and try to make sure that we're moving forward and trying to get to resolution of some of these issues and recommendations that can be good for the people of Virginia and the institutions that are involved. Is there any other question anybody else has? All right, well, thank you. We now will move on to the discussion of legislation referred to the commission during the 2020 session. We've had some overview presentations of some of this at previous meetings. We are limited in terms of a lot of things that, some limitations in terms of being able to get further information on things. And I would ask staff to talk about the different steps in the process and where we are on that and when we might be able to move forward with some of the steps of evaluation to some of the bills themselves. And just to go through all the bills, and then we'll see if there are any ones that anyone wants to pull out to have more discussion at our next meeting to move forward on these issues.
Thank you, Mr. Chairman. As you said, these were bills mandated provider and mandated benefit bills referred to the commission in 2020. The Bureau of Insurance has gone through a step one analysis, which you all heard at your last meeting, but you asked them to condense that information into a chart, which Bradley Marsh will be going over with you today.
Greetings, Mr. Chair. I'm Brad Marsh from Bureau of Insurance.
Sure. Proceed. Thank you.
Right. Let me a second here to share my screen. The information in this presentation is going to be the same that you're seeing in the sheet in front of you there. I've just sort of condensed it a little bit into a presentation. And what I'll do is give a little bit of information up front, which will hopefully let us go through the bills a little more quickly since the situation for a lot of them is the same. Right. So I just want to make sure you all can see the presentation now.
Yes, we can now.
Fantastic. Okay. So first, I just want to go quickly through the federal rules on health benefit mandates. 45 CFR 155.170 states that a state may require a qualified health plan to offer benefits in addition to the essential health benefits. But a benefit mandated by a state mandate on or after January 1st, 2012, other than for the purposes of meeting federal requirements, is considered in addition to the essential health benefits. And for those cases, the state must make defrayal payments to the enrollee or the carrier for the cost of the benefits in addition to essential health benefits. The Virginia law on health benefit mandates, section 382-6506A1 of the Code of Virginia, prohibits qualified health plans from providing any state mandated benefits imposed on or after January 1st, 2012 that are in addition to essential health benefits. QHPs are those plans offered through the individual or small group exchange, and that actually includes the off-exchange versions of those plans as well. Since these QHPs are not permitted to include any benefits in addition to EHP, state defrayal is not required by federal law for these mandates. There is, however, a concern that 38.2-6506A1 is discriminatory under federal law and could be preempted. If preempted or revised to require QHP to provide the benefit, state defrayal would be required. The reason I mention that is as we go through these bills here, you will note that there's a column that has possible cost defrayal on it. It will say yes on it, even though in the description that we have there, we don't anticipate that right now, because in our analysis right now, we are treating 38.2-6506 as if it's not preempted under federal law, but there is a possible cost of frail if it turned out under federal law that that telling the QHPs to not cover those services would be considered discriminatory. So we'll move through here, but that will be the case for a lot of the bills that we'll see here. They'll fall into that category where they would potentially result in a cost to the state, but because of 38.2-6506, they do not as of right now, based on our understanding. The first bill here is HB 39, special enrollment for pregnancy. This is where carriers are required to provide guaranteed coverage enrollment for a pregnant woman, even outside of the open enrollment period. This is not an issue with cost of frail here, but federal regulation 45 CFR 155.420 does not allow for special enrollment in qualified health plans because of pregnancy where the state's using the federal platform. Virginia will be remaining on the federal platform until 2024. So until that happens, this bill would not be allowed. Second bill here is HB 59, licensing athletic trainers. Carriers being required to reimburse services by athletic trainers. This is a mandated provider, but not a mandated benefit. And as a result, there is no determination of the applicability of essential health benefits because it's not a mandated benefit, it's a mandated provider. HB 579 is an expanded mammogram coverage. It expands the requirements of existing coverage. And the main point of this is that for folks with a family history of breast cancer, they get additional low-dose screenings for their mammograms. This is a benefit, and there is a possible cost of frail here. I'll go through this in detail right now, but I will probably just, as we go through more that are like this, just reference that the same things apply here. This mandate does expand the existing essential health benefits currently in the HB benchmark plan. Bureau's current understanding is that pursuant to 38.2-6506A1, a QHP in the individual or small group would be prohibited from providing this coverage. As such, it would not be subject to cost of frail. There is a concern, however, that Section 38.2-6506A1 is discriminatory under federal law and could be preempted. If it were preempted or revised to require QHP to provide the benefit, state or frail would be required for the benefits required in addition to the current state mandate for coverage of mammograms. HB 645, which is broader coverage for diabetes services, expands the requirements of existing coverage to include insulin, special equipment, telemedicine, self-help training and education, and it places diabetic benefits and services as exempt from any deductible. This is a benefit, and there is possible cost of frail under the same analysis that we spoke about last time. If it were determined that 38.2-605 were discriminatory, then and it were to apply to the QHPs, there would be a cost because this would be in addition to this current state mandate for coverage for diabetics. HB 776, fertility preservation for cancer patients. This would require QHPs to provide certain coverages for fertility services that are excluded coverages in the benchmark plan. This is a benefit. There is a potential cost to frail if it were to be determined that 38.2-6506 was prohibited under federal law. As of now, because it does not apply to the QHPs, there would be no cost to frail. HB 1036 for mental health screenings. It expands the requirements of existing coverage for mental health and substance use disorder services. There is currently no requirement for mental health screenings for early detection or prevention of mental health. Yes, this is a benefit. Yes, there is a potential cost to frail here, and this is under the same analysis that we've spoken about before. Currently, our understanding is that it would not apply because of the QHPs, but if it were determined that that law was not valid or was under federal law, then there would be costs that would have to be defrayed by the state. HB 1384, provider contract changes. This bill states that changes to provider contracts must be agreed to by a provider in writing. This is not a mandated benefit or provider, so there's no possible cost to frail, and there's no determination of the applicability of an EHB because it's not a mandated benefit or coverage. SB 192, physical therapist office visit. This is a cost sharing. This talks about cost sharing for physical therapist office visits, and it cannot exceed the cost sharing imposed per physician or an osteopath office visit. This is not a mandated benefit or provider. There's no possible cost to frail, and there's no determination of the applicability since it is not a mandated benefit or coverage. SB 423, this is hearing aids coverage for minors. We had a much more in-depth discussion of this back at the last meeting, but we'll revisit that here. This provides coverage for hearing aids and related services for children 18 years of age or younger without any co-payment or fee. Yes, this is a benefit, and yes, there would potentially be cost to frail for this. This bill is a little bit unique. There was an analysis done by JLARC, which was presented at the last meeting, that determined that there would be a fiscal impact of this bill. This is separate from the type of fiscal impact that would cause cost to frails, but rather that because it applies to fully insured large group plans, it would result in a cost to the state employee health plan. And Appropriation Act language stipulates that SB 423 won't go into effect if it is determined that the bill has a fiscal impact. So since JLARC's analysis determined that there would be that fiscal impact for the state plan, the bill will not go into effect. However, if we were to ignore that, the same analysis would apply that we've spoken about earlier. This would expand existing EHPs. Our current understanding is that the QHPs would be exempted from this right now. But if there was a determination that federal law preempted that, then there would be a potential cost to this applying to the QHPs. SB 1086 is coverage for infertility treatment. This is QHPs are being are requiring providers to provide certain coverages for infertility treatments that are excluded services in the benchmark plans. So this is very specifically exactly what we talk about here. Yes, it's a benefit. It's not in the benefit. It's not in the benchmark plan. There is potential cost to frail, but the same issues apply here because it's been passed and because it's because of 38.2-6506. It will not apply to the QHPs, and as our understanding is right now, would not result in any cost to frail to the state. And that would be the end of the bills that we have reviewed. Thank you, Mr. Chairman.
Thank you very much for that presentation. Are there any questions or comments?
Mr. Chairman.
Senator Serval.
Thanks. I have a question about the preemption issue that you raised repeatedly. So, I mean, what's the posture of that? Are we waiting for somebody to file suit? Are we waiting for an opinion from, the feds that this is preempted? I mean, what's going to trigger an answer to that question?
I think that's a very good question. We had a little more in-depth presentation that we were going to speak with you all on about this, and we thought that we didn't really want to blindside you all with this at this meeting. So our hope is that we can have a conversation with members of the HERC about ways to approach this and potential ways around these issues or the potential options that we have for dealing with this issue. But in terms of what would cause us to sort of realize that this is discriminatory, I am not able to speak at this time as to what exactly would be the impetus for that.
Mr. Chairman.
Yes, Senator Serval.
Thanks. So I guess what you're saying is it's not like there's a pending lawsuit in front of a court somewhere where we're waiting for an opinion to come down, right?
That is correct.
All right. And additional question, Mr. Chairman.
Senator Serval.
So is there some federal entity that issues some sort of an opinion that we're stuck with on that issue, or it's just an issue that's out there until somebody raises it in front of a judge and a judge answers the question for us?
I'm going to defer quickly to Julie Blauvelt here, who's the commissioner or the deputy commissioner in charge of life and health. I think she may have a clear response on maybe what that might look like, that what we might expect to see that would be preemption.
Yes, hi, members of the committee, Senator Serval. This is an issue that has come up several times as mandates are passed in Virginia, and we do usually, tend to highlight that this is an issue that we've heard from CMS as the entity that is the federal agency we've been talking to. and the one who put out a notice of benefit and payment parameters that kind of set out this issue in the preamble of one of those notice of benefit and payment parameters and where this was first raised for us. And they do talk about it being potentially discriminatory. So, we don't have any official determination about whether it's, definitely discriminatory, but they always do use the terms of potentially discriminatory, and potentially this could be an issue for Virginia and any other state that splits up its market and applies certain benefit mandates to part of its network and not the entire network. I'm sorry, market.
Yeah.
That does not apply to the entire market.
All right, thank you.
Mm-hmm.
Any other questions or comments? All right. Are there any of these pieces of legislation that have been referred to us that anyone would like to have more information provided prior to the next meeting and more detailed discussion?
Mr. Chairman?
Yes, Senator Searle.
One of them there, I want to say it was HB 1384, was an initial skirmish in the Surville-Goditis bill from last session that Delegate Heretic was highly involved in. And it seems to me that one ought to be talked about in the context of those other two bills at the same time and not separately. So that's one thing that immediately jumped out at me. It looks like I'm getting nodding heads on the other side of the table. So.
All right, we will highlight that one, and then we'll take it up for further discussion at the next meeting we have. So, any other bills anyone wants to flag now? All right. Is there any further discussion or issues anybody wants to raise today? And is there anyone from the public who wishes to make a comment?
Pardon me, Mr. Chair. I believe that we have members of the public in the Zoom who have signed up to comment.
All right. Can you wave them in or whatever you need to do? So.
At this time, would everyone in the Zoom room who would like to testify, please use the Zoom raise your hand function. Bree Sison, you will go first. Lee Nussbaum, you will be next.
Hi there.
Bree, please go ahead.
Okay, are you guys able to hear me now?
Yes.
Okay.
Thank you.
Thank you so much, Mr. Speaker, and to the committee for letting me speak about this. I'm very passionate, and I just wanted to encourage you guys to move SB 1086 along specifically. As an IVF mother myself, and someone whose husband took out a 401k loan against his thrift savings plan. He's in the Army, so his insurance only mandates coverage if you've had a service-related disability through TRICARE. Well, I would argue that his service has resulted in infertility for us because he was busy chasing his career, and as women age, so do their eggs. And hey, we didn't live together for 3 years or more. So kind of hard to get pregnant when you don't live with your husband. And so, things became more difficult. And it's now, not only do we have student loans, but we also have to pay back a loan for an IVF kid. And I'm proud to say, we were successful and we have a beautiful daughter, but this is not something that's uncommon among folks of my generation to wait longer to have children because they're trying to build careers. and it's difficult to do both at the same time. So I just feel passionately that this is something that should be covered by insurance, because there are all sorts of reasons why people may need this assistance. And it's a lot more prevalent than you think it is. A lot of people say just relax, it'll happen. That's not the case for a lot of us. And I just think that it is a benefit that a lot of folks should have more access to.
All right, thank you very much.
Thank you, Bree. Lee, please go ahead, and Betsy Campbell, you'll be next.
Thank you. Good afternoon, Mr. Chairman and members of the committee. It's good to see you guys again virtually. As you all know, I'm Lee Nussbaum. I'm from Norfolk, Virginia originally, although I'm technically zooming in from Manhattan, where I'm in at grad school, but I'm also a constituent of Delegate Spruill's. I won't rehash too much of my story, which this body has heard, and if you missed it for the rest of the public, you can also see it in an op-ed in the Washington Post. But just to throw out a few quick extra points here. So this December marks 40 years since Elizabeth Jordan Carr's birth. She's the first IVF baby ever conceived in the US. And I have to say, we've been emailing today, and I know that she's ready to do all she can to help make coverage in Virginia of IVF and other infertility a reality. This Friday, I also turned 32. It's a day that would normally be pretty remarkable in my family's life had my parents not used IVF. And they were lucky that they had the means to afford it. Even in the 1980s, their several rounds of IVF cost more than $30,000 in 1980s terms. That's not adjusting for inflation. I resulted from my parents' second try. Today, many people don't have that option. Since a lot of our board is up in Northern Virginia, if you adjust for inflation, what my parents spent in the late 80s, $30,000 becomes $65,124. And according to the census, Bureau of the Census, that's more than half the median household income for Fairfax County residents. So insurance coverage is going to be a game changer. It's going to give many families struggling with infertility the hope they desperately crave. And it really makes a lot of sense to take a fresh look at this issue. It's become more commonplace since the first time it was studied in the Commission on Mandated Benefits in 1990. Numerous famous people, including our former First Lady, Michelle Obama, have spoken very publicly about the long and arduous process it takes to undergo IVF. And as Ms. Campbell is going to tell you just how many states have passed fertility insurance coverage laws, Virginia's not one of them. And I know, as you all know, I worked for our current speaker. I was her chief of staff. I know you have a large to-do list. I used to prep her for these HERC meetings myself. But I strongly, strongly plead with you not to kick the can down another year and hope that instead you'll consider moving closer to legislation. I read the step one assessments as well. I understand where the BOI is trying to come from, but I also see a lot of states that provide some form of IVF coverage, but appear to comply with the ACA at the same time. And I'm sure that groups like Resolve, where Ms. Campbell is from, can provide guidance on this issue as well. But thank you so much for your time and your willingness to hear my story again, and happy to answer any questions if there happen to be any.
All right, thank you very much. Next.
Betsy Campbell, please go ahead, and Tiffany Jefferson will be next. Betsy Campbell, are you available?
Can you hear me now?
Yes.
We can.
Okay, thank you. I also want to speak about the infertility and fertility preservation bills before you. My name is Betsy Campbell. I'm Chief Engagement Officer for Resolve, the National Infertility Association, headquartered in McLean, Virginia. Across the political spectrum from New York to Arkansas, 19 states provide benefits for fertility treatment, some for decades, including Maryland, which passed the first infertility insurance law in the country in 1985. These states recognize that infertility is a disease and should be covered by private insurance like other diseases. Studies show states that cover in vitro fertilization, or IVF, have better outcomes for both mother and child and achieve long-term health care savings. Passage of the proposed legislation would position Virginia as the 20th state in the nation to help hardworking families get access to necessary fertility treatments. It will help the 1 in 8 Virginians, more than 250,000 families struggling with this disease, and thousands more who are diagnosed with cancer during their reproductive years, and others who face barriers building their families. This legislation will reduce the financial strain on families while only minimally impacting insurance premiums, if at all. A recent survey of employers by Mercer found that 97% of employers offering infertility coverage have not experienced increases in their medical costs. In fact, a 2014 study by Eastern Virginia Medical School's renowned physician, Dr. Howard Jones, estimated that the national savings from fewer multiple births would be over $6 billion a year. When patients do not have coverage for IVF and must pay out of pocket, they are more likely to transfer multiple embryos. Studies show patients in mandated states were more than twice as likely to have elective single embryo transfer. This means that insurers could potentially save tens, if not hundreds of millions of dollars a year by providing IVF coverage. Most importantly, the result is healthier babies and moms. Maryland recognized this more than 35 years ago, becoming the first state to cover IVF. And since then, they have expanded the mandate 5 times to make it more comprehensive and inclusive. This puts Virginia at a serious competitive disadvantage with reproductive age residents, many of whom can easily move to Maryland to gain more attractive fertility benefits. I understand that concern has been expressed that an infertility benefit would exceed the essential health benefits covered under the Affordable Care Act, and that the state would potentially have to defray the cost of the required benefit. I want to emphasize that determination of when a new coverage mandate would trigger a deferral requirement is entirely up to each state. Maternity care and rehabilitative and habilitative services are already considered essential health benefits.
Your time is up. Please wrap it up now quickly.
Okay, I would like to end with 8 states have passed new or expanded infertility insurance laws since 2015 after the ACA, and 11 states have passed new fertility preservation laws since 2007. Not one has been required to defray the cost, and we're happy to work with Virginia to ensure the same. Thank you.
Tiffany Jefferson, please go ahead. Barbara Kalura, you'll be next.
Good afternoon. My name is Tiffany Jefferson, and I am a proud resident and constituent of the capital of Virginia, the city of Richmond. I stand before you on behalf of myself, my husband, and the community of couples and people who suffer from the disease of infertility, could benefit from fertility treatment and or fertility preservation. House Joint Resolution number 545 and Senate Bill 1086. When I was a child, I was told that this is how it will be. First comes love, then comes marriage, and then comes the baby in the baby carriage. You all remember that infamous nursery rhyme. Before love, I was taught to finish school and go to college and get a degree, find a good job, and make sure you have some place stable to live. Well, I did all of that. If you ask me, I am ready, willing, and able to be a parent and raise a family of my own. Unfortunately, infertility was never a part of the birds and bees conversation. We didn't learn about it in health class or sex education. All we knew is that if we kissed a boy, we would get pregnant. We were told that it was just that easy. Oh, well, you can imagine my shock when I learned that I had been lied to my entire life. When my now husband told his family that he was in love with an older woman, a woman who was 7 years older than him, he was warned that we would face infertility issues because of me, because of my age, and because of my age alone. I was so angry when he told me this. I am thankful, though, that he did not let that scare him and decided to marry me anyway. We were married on August 1st, 2020, and recently celebrated our first year of marriage. Shortly after we were married, I took the lead by having a fertility evaluation done at a local practice. My husband was required to be a part of this evaluation too. This was covered by insurance, and to my excitement, the evaluation determined that my stats looked great and conceiving would not be an obvious issue for me. Unfortunately, this was not the same result for my husband. His semen analysis showed that he had a significantly low sperm count and poor sperm quality at just 27 years old. In other words, he does not have significant sperm in order to impregnate me naturally. All of his testing showed that this was a result of very low testosterone. And our treatment recommendation, IVF. So my husband and I are not alone. 50% of couples cannot conceive due to male factor infertility and due to no fault of their own. We are that cute couple you have seen and ask, where are the kids? Well, the answer is we can't afford them. As newlyweds, you can imagine our goals: paying off debt, buying a home, and saving for the future. We would love to be able to do this with our money instead of going into debt just to have a family. We know that if we simply move someplace close by, like Maryland, we will be guaranteed fertility coverage. However, moving is not that simple, as our family, community, work, and lives are here in Virginia. We love Virginia, and Virginia is for lovers. Virginia is for children, and Virginia is for families. So I am asking that Virginia join almost half of the other states in the United States of America and mandate that insurance providers provide complete coverage for infertility and allow Virginia families to build the family of their dreams. Every year, our fertility declines. So we cannot wait another year. Let's study and enact this bill now. Thank you very much.
All right, next.
Barbara Kalua, please go ahead. And I'd like to remind all of our attendees via Zoom at this time to please use the Zoom virtual raise your hand feature to ask to speak.
Hi, Mr. Chairman and committee. Thank you so much for this opportunity. My name is Barbara Kulora. I'm a resident of Herndon, Virginia in Fairfax County, and I'm also the president and CEO of Resolve, the National Infertility Association, which is based in McLean, Virginia. We are a nearly 50-year-old patient advocacy organization that supports people across the country in their quest to build their family. So I want to first of all offer myself, you just heard from Betsy Campbell, and our entire staff as a resource to all of you. We are here in Virginia, we are headquartered in Virginia, and we would love nothing more than to work with the state legislature on this issue. As Betsy has described, we have a wealth of experience across the country in other states, and we would be delighted to share that experience with all of you. Again, we're based in McLean, Virginia, and are at your disposal. I'm just going to take about 20 seconds to say how important this is. We hear from Virginia families every single day about how the barriers in the state of Virginia have made such a profound difference on their life and their inability to become parents and to grow their family. I would love to be able to say that I live in a state that is family building friendly. And we hope that Virginia becomes that 20th state. Lee Nussbaum at the top of this testimony shared her history, but also the unique position that Virginia has. We are the state where the first IVF baby in the United States was ever born. That was in 1981 at the what is now the Jones Institute. At the time, it was Eastern Virginia Medical School in Norfolk. And here we are all these years later, and we are still having this discussion and still talking about, is infertility a disease and do people deserve to access care? So I hope that, as Lee said, we can change history and make Virginia a state that is family building friendly. Thank you so much.
Thank you. Next.
Mr. Chair, at this time, I see no more members of the public attending virtually who wish to speak. Are there any members are there any members of the public in the audience in person who wish to speak at this time? Please.
All right, come forward, please.
Mr. Chair, members of the Health Insurance Reform Commission, my name is Mike Puglia. I'm a certified athletic trainer. I work for Virginia Commonwealth University Health Sports Medicine. I'm here representing the Virginia Athletic Trainers Association. I'd like to speak on House Bill 59. We hope that you guys would vote in favor to move HB 59 forward. This would give athletic trainers who are qualified, highly qualified healthcare professionals who are licensed here in the state of Virginia and nationally board certified to be reimbursed for services, healthcare services that we are legally allowed to render to patients in a rehabilitation setting. So we have national provider identification numbers, our own set of CPT codes and taxonomy codes. The current landscape in Virginia is that we've got athletic trainers who are rendering these services and they are having difficulty being reimbursed for these services. So we would hope, based on just the landscape, on the favorable analysis from the BOI, that you guys would vote in favor of moving our HB 59 forward this legislative session to be voted on. Thank you.
Thank you. Is there anyone else?
Good afternoon. I'm Doug Gray, Executive Director of the Virginia Association of Health Plans, and I just want to make a few comments about what we've looked at today. I wanted, just for context purposes, to remind everyone that these are the 2020 bills. Right. We haven't even started on the 2021 bills. We are in a situation where we've lost 300,000 people in the individual and small group markets over the last 5 years due to cost and a number of other problems. We've had a little bounce back with some increased subsidies recently, which may or may not become permanent, but we don't know yet. We've had a little stabilization of the market. We've had a couple of new carriers come back a couple new one new and one come back. So we've had, in context, we're coming out of a very difficult time. We have a long list of wants here, and we have a challenge trying to figure out how you could change the essential health benefit to permit this. And there's going to be a further conversation about that. And when you whittle down what you might want to pursue in context of that conversation about how you could change to a different benefit and or pay for the services as you might be required to do, then we can kind of figure out what out of this group you want to go forward with. But you also have a whole nother group that you need to hear and discuss and think about the total amount. I would remind you, which I should do more often than annually, that 24% of the market is under your direct influence. And those are the fully insured people in Virginia. 4% are in the individual market, 4% in the small group market, and 16% in the large group market. The large group fully insured are between 50 and 200 people, and generally are a company that's decided they'd rather have a fully insured product than go self-insured, although some have self-insured at lower numbers than 200. The self-insured are not under your purview. They're under the purview of the ERISA laws at the federal level. Neither is Medicare or Medicaid fully. You have some influence, but not total decisions. So in the end, you really have that 24%. And this discussion about whether individual and small group can offer additional benefits after 2011 is a big deal. If you can, you're going to have to pay for it. and that's clear by the regulations today. So you need to think carefully about what you do as you look at this backlog of work between the 2 years. And so those are just some comments I would share with you. There are 2 bills in here where it really hasn't been made clear that not only does the bill mandate a new benefit, but it mandates that it be provided at no cost share or not applied to a deductible. That conflicts with federal laws as well, particularly for high deductible plans. And it also conflicts with preventative services, which are decided at the national level by a national foundation that basically makes a set of recommendations, to USPTF, I believe, and that is what has to be provided with no cost share. But for example, the mental health screenings required 6 screenings at no cost share. That is not just a mandate, it's a mandate times 2 at a minimum. So these are things you need to think about as you go through the process going forward. So thanks for the opportunity to offer you a few comments.
Thank you. Anybody else wish to speak? All right. Thank you all for coming, and we will be scheduling another meeting to pick up where we left off here, and we'll get going on the stakeholder group to deal with the issues that Chesapeake and Centerra brought before us today, and trying to get to a resolution of that in an amicable way. And with that, then we are adjourned. Thank you.